panelist is Professor Belington Vwalika. He is also a professor at the University of Zambia, and he is Secretary General of ECSACOG. Please, Prof. Vwalika. And the third panelist is Professor Rulisa, who is a professor at the University of Rwanda and the chair of ECSACOG Training and Research Committee. Welcome, Professor Rulisa. And our last panelist is Professor Delayehu Bekele. He is a professor of maternal medicine in Ethiopia and the director of Center for Institute of Reproductive Therapies. So welcome all the panelists to the podium.
Can we have reduced noise from the people at the back, please?
So as I said, there will be a round of questions for all the four panelists, and then because of the interest of time, the time given for each panelist will be 5 to 10 minutes, and then the rest of time will be dedicated for discussion. So because some of the points has been raised in the previous panel discussion, then it will be an opportunity to skip some of the questions. So Professor Belington Vwalika will be discussing on the current landscape and abortion laws policies across Africa, and Professor Annette Nakimuli will discuss about the current research condition and research output and challenges regarding to evidence generation. Professor Rulisa will be discussing on the role of advocacy and the role of ECSACOG in advocacy for abortion across Africa, and Professor Delayehu will be sharing the best practices and collaborations made between SPEAR and ECSACOG. So I'll be proceeding to the first question to Professor Belington. So some of the points have been raised in the previous panel discussion, but in general you can highlight on the current landscape of abortion laws across Africa and which are the progressive countries currently, and also what are some of the challenges, opportunities in advancing abortion rights across Africa. So you can go ahead with those questions and quick review.
Thank you, Dr. Malede. I think I similarly answered the first question about the landscape of abortion laws in Africa, particularly ECSAC. And I hinted that most of the laws are restrictive, and we inherited these laws from our colonial masters who have gone back to their countries and made them liberal. But us will stay with the old laws, which are very, very restrictive. So to mention, in our ECSA region, I hinted again that Zambia has not made any progress, but mostly inherited a law that was liberal in what is called the 1972 Abortion Act. But then this does not translate into practice. We have different challenges, personal beliefs. Some people are ignorant about the law. We've had times when even policemen did not know about the law and ended up arresting people unnecessarily. So knowledge about the law is a challenge. We've seen progress in countries such as Rwanda to some extent. The law is liberal. We've had an opportunity in Malawi to sort of enact a law that was going to make abortion liberal, but this was shot down at the last minute when the president was supposed to assent to the law, which was nicely advocated for to become liberal. Apart from these countries that have mentioned, Rwanda and Zambia, in the rest of the countries, abortion is only allowed usually to save the life of the mother. And service provision, it is restricted. Now, what are the challenges and opportunities? Well, as we are advocating for change of the laws, there are also other groups of people who are promoting that abortion should not be allowed. So that is a challenge. But what are the opportunities for advancing abortion rights? It has been mentioned in this meeting that we are the champions for women's rights. We know what happens. We know the numbers, and the numbers don't lie. And therefore, this is an opportunity for us to advance some of these women's rights. We should engage lawmakers, the church leaders in making sure that abortion services are given as a human right to our women. So, just to mention that even those who provide the services for abortion, no one really wants to do an abortion just for the sake of it. And we've heard again in this meeting that there are several layers. If somebody is religious, they can play a role, for example, by promoting contraceptives, and therefore you don't end up with unintended pregnancies, which is abortion. Thank you.
So, restrictive law doesn't mean that's illegal, right? So there are set of indications for which the service can be provided. So do you believe that in these countries or in Africa in general, women are getting the abortion service as mentioned by the law? Or do you see some kind of strong resistance from the providers?
Well, the providers are constrained because the laws are restrictive. As I indicated, most of the laws just allow abortion when the life of a woman is in danger. And yet, most women have circumstances under which they have no option but to want termination.
Okay, so thank you very much, Professor Belington. So I'll be proceeding to Prof. Annette. So as you know, research is an important element in policy advocacy and in advancing the studies. So how do you see the research output related to family planning and abortion particularly? And how do you see the role of ECSACOG? ECSACOG is a training organization. We have trainers. How do you see, or what's your comment regarding promoting abortion and reproductive as the main research output by our residency program and by our trainers?
Okay, thank you. Morning, everyone. We're having a very interesting discussion. Before I delve into the question, I observed that this is not just in this meeting. The abortion discussion is usually on the last day. And then people go and then the next discuss as one of the last days in another meeting. So it doesn't give opportunity for discussion outside the meeting about the same. So I've been asked about research in regard to abortion in the region. ECSACOG is 11 countries now. We have 3 more soon to join that would limit especially operational research, which could be useful to influence policy and practice. So it's hard to divorce the research from the practice because of the law. And I don't really want, in the interest of time, to belabor that point. I would like to really go into how ECSACOG can help in this endeavor. As ECSACOG, we are training general obs guide and soon specialists, subspecialists. But already we are doing some things to try and improve the death and morbidity that comes from abortion. Abortions are not top 5 causes of maternal death in our region, but they are rarely among the top 5 priority areas in any research agenda, including my country. Again, going back to the stigma and the restrictive laws. But I think it's more of stigma in the case of research. So what we can do about it as ECSACOG, and we're in the process of formulating the research agenda as a college, which can be utilized by our trainees, by the fellows and members of the college, but also which we can sell to others, especially as we advocate for funding to the college to improve research. So it is to try and see how we really make it one of those priority areas on our research agenda. And one of the ways, so that is one way ECSACOG can help, and this would be a regional research agenda, as you can see, since it will have had input from all the 11 plus 3 member states. The other one is the committee of practice we just heard about in the before break. which we've allowed to exist within our structures. It's not there from the outset. And it actually has a very clear reporting mechanism now through the registrar into the council. So we get updates. What is it? How is this helping? I think it's also helping to make sure abortion remains on the agenda, but also to see what is doable within our different legal environments. So the committee of practice is one thing we think ECSACOG can really build on to improve research in this area. The other is to provide a dissemination platform. Many times we are asked by our members, what is it I benefit from being a member or fellow of the college? So we are trying to come up with packages, short courses, other trainings, and we think this could be one of those we develop. And there's a curriculum, I think Professor Delayehu mentioned, which could actually benefit those both in practice and those in training to improve their knowledge, their skills in matters of abortion. So it is also what we can do, but the other clear dissemination is meetings like this where we are discussing this topic, which is not comfortable for many people in the room, but we have to discuss it. It's killing our mothers, and no one else will discuss it without us taking the lead. So that is one area, and I'll quickly go to others. ECSACOG has been involved in workshops, values clarification workshops, which have happened in some of our member countries, but sometimes also involve those outside those countries, because we know this is very important for making members really understand what their role is in this whole entire abortion agenda, research and practice. When we don't discuss things we are not comfortable with, we stagnate, and when we stagnate, we shall continue lamenting about how we've not achieved progress in reducing maternal mortality as we ride towards the MDG target of 2030. And we know that actually abortions are the elephant in the room. People are bleeding, people are getting infections, and sometimes we classify them in other things, but we know that the tap is open and we are just mopping the floor. I would like to also say that ECSACOG has another opportunity to engage with policymakers. We are, as a college, we are a member of the ECSA College of Health Sciences, and I want people to all get to know that. All the colleges, professional colleges belong under the College of Health Sciences of ECSA, which is based in Arusha. And every year, once about for 5 days, we have as presidents, registrars of the colleges, secretary generals, we interact with the ministers of health. And you know we came into being as colleges by resolution by our ministers of health. And we usually discuss those issues that are very pertinent to us as a region. And I think as ECSACOG, we need to move and put abortion on the agenda of those things. And one of the forums is called the best practices. And I see that this is really a low-hanging fruit for us to utilize and bring the agenda. So in those things, usually you gain much more than you imagine. All ministers are there in a very relaxed state, and they listen to what they would not ideally listen to when they are under political pressure in their countries. And I know we just had one recently in Arusha, and so I think ECSACOG again showing that opportunity. I think, Chair, I can pause there and...
So maybe just one point to give you one information. For example, our trainees, our residents are on the phase of undertaking research, but from the topics of they submitted, only there is 1 or 2 residents who chose on the line of comprehensive reproductive research agenda. The rest are on maternal health, gynecology, and so on. So you can see how the research agenda is skewed to that aspect of research. Okay. So what kind of skill can we put in place to encourage them to go into more research in abortion and family planning?
Yeah, the good thing, the supervisors are in this room. Our students, the first note is just beginning to work on their research project, their third years. And the arrangement is that they usually have an in-country mentor, supervisor, and then someone from another country. So it is the supervisors who need to be converted first, because we know that some come up with these topics and then they get discouraged. And I cannot going to work in that. I mean, that's not my area. That's not something I'm comfortable with. So even before I think about what to do with our trainings and topics, I think what we are doing is part of the awareness that we need to have these put on our research agenda via our students and ourselves, and then we shall have especially confidence built that these are worthwhile things to investigate in our setting. But I think the fact that we have one is really not terrible. I think there are 20 students. I know that usually we zero, even at Makerere, except when I think AOGU really was proactive and supported some people to do research in this area. Otherwise, it was not featuring much.
So thank you very much, Prof. Annette. So the next question will be to Professor Rulisa. So some of the points has been raised from the previous panel. So the role of advocacy is very, very important. There is no doubt. From research, evidence generation to policy advocacy is one of the important. As the rest things will not be materialized. So in relation to that, particularly, how do you see ECSACOG's role as a lead advocate in ECSA region to bring about wider access and then the implementation of the laws and so on? Do you recommend and how can we go as ECSACOG?
Thank you very much for that. I think ECSACOG has a unique opportunity because it is a regional body, and the body encompasses different countries with different laws at different levels of enforcement. I like the gentleman there who is soon migrating from medical to politics. Politics here the languages of other politicians. So it would be very interesting when a politician from one country which has advanced abortion and reproductive rights laws to hear from them. So other countries can learn from each other by peer-to-peer, politician to politician, other than healthcare professionals talking to politicians. So I think we stand a better opportunity in the region because we are at different levels of government and the laws are different. But if you hear from one country which did it and has a result, the other countries may learn from it, and I think that is the opportunity. And then we have also free movement of healthcare professionals. If you train with ECSACOG, you can train in Zambia and work in Rwanda with no restrictions. And then you carry, of course, the expertise you acquired from there. That goes with advocacy and so on. So I think ECSACOG stands a very unique opportunity in terms of advocacy.
So maybe you will enrich that upon question and answer discussion. So let me go to Professor Delayehu. So Professor Delayehu is the director of St. Paul Institute of Reproductive Rights. And this organization is a champion in advancing reproductive training and advocacy, and also research in general. It has been there for some time. So I just want you to share the experience of the SPEAR and in general at St. Paul in advancing this care and also integrating reproductive abortion services into the residency training and also creating champions.
Okay. Thank you, Dr. Malede. So, talking about the best practice of the country in general, it was a little bit touched earlier. It's very important to put context into what we are doing, and we start with that one briefly. You know, Ethiopia is one of the highest maternal mortality, especially from abortion, from massive abortion, as previously mentioned, contributing for around 72% of maternal deaths before 2 decades. And this was mainly due to the restrictive abortion law and implementation challenge of even that very restrictive abortion law. And in 2005, there was a movement by led by scholars, civil societies, including the Ethiopian Society of OBGYN, Ethiopian Women Law Association, and so on, seeing that there, fact, there was a big movement, dialogue, and advocacy work, and discussion with parliamentarians and other legal bodies, and there was a change in the abortion law, which has made it a bit, not completely liberal, but provisions in which abortion would be done were expanded, but most importantly, the actual implementation of that abortion law was left to the Ministry of Health, asked to the Ministry of Health to prepare a technical and procedural guideline in which how that is implemented, and that is prepared by people who knows the problem at the ministry and also the different health facilities. So it was made in a way that it is very accommodative and that leaves we take the woman's word for whatever indications they have, and also it's a provider's discretion, to take that and also to provide service. So currently, as long as provider the woman is getting is have the necessary knowledge and skills, and also positive values and attitudes, access to self-abortion is at a very good state, you can say, and there is a dramatic reduction in the contribution of self-abortion in to the maternal mortality, and according to today's report, the contribution of abortion now is less than 1%. The last MP's report. So, because the knowledge and the skill of the providers and their value and attitude is very important, that the training as pre-service training in the postgraduate program is very crucial to sustain such kind of gains, and that's what we worked at our college at St. Paul's. So what we did at St. Paul's is to give emphasis and attention to abortion, family planning, and other SRL services. There is a dedicated attachment in each year of the residents, like they would have a rotation in oncology or urogynecology and MFM and so on. One of the areas in which residents need to work for determined time is SRH clinics, where comprehensive abortion care is provided, family planning and other SRH services, which call them mature clinics. The service is organized in a way that it is woman-centered and there is no gatekeepers, and the woman gets her service there, and at the same time trainees have the chance to attach there and also develop the necessary knowledge, skills, and to develop positive attitude and values towards self-abortion, and they become champions after they graduate to wherever they are assigned. This is bringing a very big shift in the way of thought and practice among the OBGYNs. And the other thing is we have also a dedicated family planning and SRH fellowship, subspecialty program, which mainly one of the area of interest for that fellowship is comprehensive abortion care, plus family planning and as a SRH service. And we have graduates from that program which are expanding the service and becoming a very big advocates. And we are proud, like the current Minister of Health is one of the graduates of that fellowship or subspecialty program, and you can imagine the impact it will have as a country when you have such kind of individuals at very influential bodies. So all this experience from St. Paul's is going to help even other countries to follow the same suit, and to help also expand this to other ECSACOG countries. We have fellows, subspecialists coming. We have from Rwanda and a new one who's going to join us soon from Zambia, which we think will create similar champions, which will do replicate similar things in their countries. Thank you.
Thank you, Prof. So maybe to add one question. So St. Paul and ECSACOG have more or less similar kind of curriculum in the residency program, in which reproductive health or SRH is integrated into the residency program. So the experience and the achievement of St. Paul over the past 10 years in producing new generation of OBGYNs who do not have a problem, have a very improved attitude to provide CAG services is a very good lesson that can be translated into ECSACOG, because ECSACOG is existing like in more than 10 countries. Plus, as you said, you have advanced into subspecialty training and then producing advocates, and also one of them is administered now. So that will have a huge impact. So looking to that, how do you see the partnership between SPEAR and ECSACOG? How this is a synergy to advance like advocacy, the influence both these organizations have in accelerating the landscape situation in Africa?
Thank you. Yeah, so as I mentioned earlier, through many years of work, such kind of achievements and platforms have been created in country, and especially also at Salesforce, and experience sharing from that side. It can be in terms of the organization of the service, the way the curriculum are designed, and not only the curriculum design, but what's being implemented on ground would be very important to expand similar type of experience into the other ECSACOG countries, and also, again, as I mentioned earlier, having more fellows, subspecialists to come from other ECSACOG countries to have the training with us and to go back and be a champion and actually create an environment which would look like the lot of ours would be of paramount importance to accelerate and to bring change fast. And the other one is the research which was raised earlier, doing collaborative research, because it is one of the 5 subspecialty programs, and it's equally given attention like the others. There are many research among residents and faculty which are in the area of abortion. This type of research can be done as a multi-country, multi-site research, and we can collaborate in those areas will be one of the things we can do.
Okay, so thank you so much. So I think it's time for the general discussion. Then I'll give the first round of questions, maybe for 6 people, and then because we have time, we will go for second round of questions. So maybe can you assist me by sharing these mics? So the first is for Prof. Kiara. Okay, second, third, fourth. Okay, 4 hands only. Okay, so yeah, you can proceed.
Thank you very much. I really want us not to leave here just thinking legal restriction. I think even the interpretation of the legislature and implementation are the bigger problem. Number 2, in a lot of our countries is the discrepancy between the legislature and the penal code. And that's really where the fear of clinicians comes in, because it's punitive. The third layer is the scope of practice and what regulates given providers to provide care. The fourth is then the curriculum, pre-service, in-service. I like what is happening in St. Paul's, but I want to ask pertinent questions even with St. Paul's. Resource to conduct research, resource to have those exchange programs of students, and resources for service delivery. And even beyond the training, have we thought of using a hybrid model where we don't just have to have everybody move to St. Paul's to get this training? That's one. And number 3 is really the thinking around, yes, you created the advocate. We know subsequent resourcing for advocacy is more expensive because it takes a longer time. It's not like a quantitative thing that you're doing and you get results immediately. So what are we doing in terms of even funding advocacy as its own entity? And lastly, sustaining and scaling. Where are we getting those added partnerships and people to collaborate with and other philanthropy people to really keep that agenda going, whether it's at St. Paul's or even within the ECSACOG region?
Thank you. So, second.
Thank you very much to our panelists. Continuing with this, my name is Mike Kagawa. Continuing with part of what the President has just said. One of the opportunities we have where we talk about abortion is allowed when the woman's life is in danger. My question is, how elastic is this definition? Does it include mental health for these mothers? For example, can we define the woman's life in danger to include mental health? Usually when these people from the legal fraternity phrase these laws, they actually always leave a window of opportunity. Have we exploited this window? Thank you very much.
Okay, at the back.
Okay, thank you. My name is Rulisa, and today I think allow me to submit on behalf of the Gen Zs that are not in the building. I think the conversation around abortion is a tricky one because it is surrounded by fear and morality and all that. I think that's why it's very controversial, it is very emotional. But we should also agree that yesterday Professor Valentino was talking about the change in the sexuality that is happening now. But then the reality that lives with us today is that there is more abortion happening than we actually know. So that is the reality we live in. But if this is to be brought up and the discussion is to come out, someone has to accept to be demonized by the public because that is how they receive. Given the context that we live in, an African region that is rooted on morality. So for me, I think it's only wise because I in this room I think I'm seated with the people who make the decisions and advise probably. I think it's high time that we woke up to the reality that there is actually more abortion happening than we actually know. And we need to have this conversation, however uncomfortable it is. And because we are the practitioners, I think we are the ones to look at this and see how far we can go. And the fear that the moment you become a victim, then what happens should also be addressed. So for me, I feel I don't know if the panelists and the policy makers in this building are willing to be so intentional. And I feel we really need to have this conversation, however emotional it is. And maybe my challenge is that we need to really speak up and make sure maybe these issues are addressed once and for all. I thought I should give that comment. Thank you.
Thank you. So, Prof.
Thank you. So mine are just two comments. One regarding the advocacy. So still we have to continue to educate the community and the public at large. So we know that there is an issue of morality, but on the other hand, whether we like to or not, women are dying because of the restrictive laws. So the restrictive laws are just making the abortion process dangerous. But otherwise, the abortion is still happening. So why don't we make or reform these laws and policies so as to provide safe abortion care? On the other hand, while we are working still to prevent pregnancy, of course, but that will take time, and resource, definitely. So unless we educate the public to prevent pregnancy, they will end up definitely having an unwanted and unplanned pregnancy. So if we don't refine or reform our laws and policies, they will end up having unsafe abortion because of restrictive abortion laws. Then the other is regarding training and skills. As has been said in ECSACOG training, the curriculum was fine-tuned to do competency-based abortion training, academic workshops were conducted. We know that member countries are different level when it comes to abortion laws. But wherever it is, at least providers should be able to provide on conditions of maternal health related, at least safe abortion care. I mean, wherever it's restricted, at least there is a provision related to maternal health. So they require one way or the other, they require this scheme to provide a safe service. Thank you, Chair.
So thank you. Thank you can respond for all of this. Let me begin. Let me begin from you.
You can see the stick passing me that mic. I think I will say some of the things. Some are comments really well taken, food for thought, and we take them in good faith and we reflect on them as ECSACOG, especially what has come from Professor Kihara, the Gen Z, and others. But maybe to say to our young colleagues that actually abortions, time immemorial, many are done and are not counted. So it's not a new phenomenon. We know we don't have accurate numbers. Even when we try to advocate, and that's where the problem is, when we don't have good, accurate data. They don't feature as prominently as they should because they are hidden in many ways. So that's why we need to do research to inform our advocacy. That was the issue from Dr. Kagawa. I don't know why you really asked that question. Interpretation of the law. I mean, even in Uganda here, where they say you can, one of the indications is to save a woman's life. I know this is some discussion we always have. And there's a feeling that we've not explored. I think also Anne has said it, that law fully, because it seems to be quite elastic or as open as you can have it. And Dr. Psike in the room. I remember once in a while this question came up, someone says, who will bail the cat? Someone needs to go in, prove, do something that will trigger a precedent to be set. I think we are all cowards. No one has wanted to interpret it in so many ways. What is it's Professor Kaye looking at me. Professor Kaye, where we don't answer, I will ask you. But I just wanted to say, mental well-being as being part of saving a woman's life for mental ill health. We all see that there is a provision there to utilize that law to do much more. But who is brave enough to set that precedent? Because usually when that precedent is set, a lot of things then start happening. I'm leaving it at that. And then I think I will allow Professor Rulisa to say when it comes from a country where they've managed to overcome some of the challenges we are still working with.
Thank you. Let me talk about the question of elasticity of the question whether women are in danger or not. We did a study in Rwanda about this. The question we usually forget is that healthcare professionals are part of the community. So when you do sensitization or mobilization, whichever way you want, we usually forget to sensitize doctors. And they are part of the community. The religion affects them, the culture affects them. Knowledge alone, the science we get in the classroom is not enough to transform our understanding of this question. We came from the backgrounds of our communities and our religion and beliefs and so on. So I think where we have to start is there. Also sensitize healthcare professionals. And that's where the big problem is. Actually, the study we did, we found that the biggest barrier, even when our laws were changed, the biggest barrier was in healthcare professionals, not among the communities. Women were willing to come, but if they come and the doctor or a nurse start questioning them, oh, you want to kill that baby? nurse who went to do clandestine abortion, like the doctor said, these laws are not going to reduce abortions. They are going to make them worse because you prevented them, but the rate of sex or act of abortion will continue, only in a different way, in background. So what we have to do is start sensitization from healthcare professionals. In my hospital, there used to be, at that time I was a dean of medical school and I teach this stuff and I encourage my students to come forward. But when you come to my consultation, the nurse will ask, what's your name, what's your gender, who is your husband? And the guy is like, I don't have a husband. He's like, what do you come to see a gynecologist? That is already a barrier within an institution that you should promote it. And the nurse would say, hi, young girl, what are you coming to see? Are you married? Once we ask these questions, we are already being barriers and the healthcare professionals. So I think the sensitization should start from the healthcare professionals first. The community is always open. If we change, we change. But if we don't, and usually they learn faster and change than the healthcare professionals. So I think we have to start by ourselves. We can't assume simply because you are a medical doctor or a gynecologist or a midwife that you are completely transformed. It's not entirely correct. Thank you. Let me name it.
Thank you. Let me respond to Professor Chiara's comments. They are very valid comments in terms of resource. Yeah, we can't do anything without necessary resource, and I see it in two ways. One is there are things which we can do with minimal or no resource, like the service organization, the including of the training, the way it was organized and so on, are not something which might necessarily need large amount of resources. And working on getting the emphasis and appropriate attention it needs is something which can be done easily, and like any other, let's say the research is there of comprehensive abortion care and so on. Once those elements are there, the attention is there, residents would be choosing like any other topics of oncology or gynecology and so on. CAC is one of the area, and with a limited resource which will be assigned to any ways for any of the disciplines, they will do it. But there are other things like you have mentioned, exchange visits and so on, to share it for other example countries and so on. Resource intensive, as you rightly said, and this needs like us to be active in grantmanship and getting funds from different philanthropies, as you have mentioned, or localization of course of the financing, because we are going to have challenges, as you mentioned earlier, with the election of let's say Trump and so on. So working with local bodies also to have some local financing would be very important. And regarding the making the training to where physicians are and so on, or hybrid model. So what we are taking is now expanding the program, because now we have more than 15 OBGYN residency programs in the country. So we are working to have similar type of engagement in comprehensive abortion care, those trainings in those 15 residency programs. And even we are expanding to working to expand the fellowship, the subspecialty program to other universities, and we have just finalized to start in one of the northwestern part of the country in another university to start the second fellowship program. And this would be a big move. That way we can make it closer to where the physicians are. Yeah, thank you.
Okay, thank you, Prof. So I just want to stress what Professor Rulisa said. So as a professional or OBGYN community, I believe, and we all believe, that we have to be the voice of women. Okay, so without manipulating and further revision of the law, within the scope of the law, if we have a very good attitude and do not have some kind of resistance, we can still do a lot and then provide certain reduce maternal mortality because of massive abortion. Earlier, one of the researchers presented from Uganda reported that 30% of cases are referred from health centers. So significant proportions might be because of some kind of poor attitude, okay? So if we improve that, and if we become a voice and advocate for those, then we can improve. So let me give, I think there's a question from Professor.
Okay, thank you very much. I am afraid of being seen as a black sheep of the language. You see, I think our approach is a top-bottom approach. But what we want to do should be expertise, is the welfare of the community and the welfare of the people. So it should be people-centered, community-centered. But who is thinking for the welfare of the community and the people? We have taken over this responsibility from the top. So we decide what is better for the people in the community. So it is a top-bottom approach. Probably this is one of the problems. And when we see that some countries, for example, they have succeeded in this approach, then it sounds, or maybe it smells of authoritarian approach. I'm not saying that it was authoritarian, but when it comes from top-bottom, then it's more of a authoritarian. It smells of authoritarian approach. We are imposing what we think is good and better for the people and community. So I think that we are becoming like the animal farm model of H.G. Wells, that we are the brain. Anyway, so why don't we have a bottom-up approach? I hope I'm not misunderstood when it says bottoms-up. So the bottom-up approach, we go to the community and see what they want, what are their preferences, what are their worries. Instead of we thinking that we know what they want and we impose on them. So the bottom-up approach, how do we go from the bottom-up approach? And then we must not be seen that we are implementing other people's agenda. This agenda must emanate from the community, from the people. But the way we see it is as if we are implementing other people's agenda. So we must not be seen like that. So I think in short is how do we change this approach from top-bottom to bottom-up? So how do we go about it?
Thank you very much for those comments. And ladies and gentlemen, I think chapter 1 of all our constitutions clearly indicates that you will comply with the international treaties and covenants your individualized countries have ratified. That really gives us that elasticity in terms of abortion care services. But that's not where I really want to go. I want to focus a little bit more on the Africa we want. 2063, prosperous communities, citizen. In talking about the Africa we want, let us focus on the Maputo program of action. And this really speaks then to your top-down and down-up. I won't say bottom-up, but yes. Political commitment is number 1. Respect of rights is very clear. The rights to health, including reproductive health. I think really that's the main thing. But as you even read further and further, it gives investment case, it gives you the healthcare provisions. There is accountability. And accountability is really the feedback mechanism that speaks bottom up and also up down, because the kind of work you do as a service provider, you should be accountable. The duty bearers who really run the show for all of us, we should be accountable. And unfortunately, that's the mechanism we don't seem to invoke as much. Move fast forward to ICPD. We're now at plus 30. ICPD, the last one, which was held in Nairobi, talked about 3 things. Reduction of the unmet need for family planning. It's in black and white. So my Gen Z, who's telling us they're more sexually active, what are we doing in that group? Harmful cultural practices. And I will even add there, the teenage pregnancy to me is a harmful cultural practice. Should we be having girl childs leaving school or persistently remaining in school to be the best that they can be? And the third one is preventable maternal mortality. 0 rate that. Is abortion agenda there? Yes, in black and white. So we have documents that really push it. My worry is this. When I compare Africa, where declarations and charters have been given, even in country related to abortion, we don't seem to carry it through. Comparatively with Ireland, comparatively with Papua region. I think that really should be the conversation. Are we keen to value women enough to save their lives? Late Mohammed Fatah was very clear. And as long as we keep on dancing around, what is there, what is not there, are we valuing the woman who is really bearing the brunt of the problem?
Thank you very much. I want to talk about the implementation of the laws. Yes, laws can be there and they are good for all of us, but doesn't mean that one of the people who talk about abortion sometimes are misrepresented as if they are advocates for the law to be changed. There are very many people who don't support the law to be changed. But within the existing law, there is a lot of work that we can do. For our other association, I'm not a spokesperson, that's my disclaimer. There is a lot we do about harm reduction. We know abortion is happening. The abortion that will occur, which causes morbidity and mortality, where people self-induce, are because those individuals, however few, are concerned about themselves and provide their own self-care, which unfortunately leads to abortion complications. There is a lot we can do about harm reduction, whereby we follow the public health approach of comprehensive abortion care. Primary prevention, whereby leaders can do their job. For us, we can help educate, self-awareness about family planning, even provide family planning. There is a lot that we can do to advocate to those people who have unintended pregnancy. Many accept to keep them pregnant. Some don't. You can warn them of danger signs of abortion complications. For those who are determined, depending on their values, they can provide safe abortion. Many of us don't. But we're advocates of safe abortion, that we want people not to die from abortion complications, and all of us should provide post-abortion care. The other approach that we can do is decriminalization of abortion. We have engaged in many of these religious leaders, many of the legal providers, prosecutors. Dr. Kayo here is keeping quiet. But in our project on advocacy for prevention of morbidity and mortality from abortion, we engage many of them and we continue. Many of them look at the law, but as humans, they see that people are forced between the law and hard place. And when it comes to passing judgments, they pass with a human heart. They know, okay, somebody may have done something wrong, but what are the underlying circumstances? The mitigating factor that forced the individual to do that. So that's the way. We can leave the law to be on paper, but there is the law that can do prevent death from women who suffer abortion complications. So that we can stop the abortions if we can, the pregnancies if we can, but if we don't, we can all have a humane approach where we can reduce the deaths from abortion complications our way. Religious leaders can do their job, We providers can do our job, policymakers could do their role, but all of us can identify a role we can play to prevent women dying from abortion complications. When it comes to abortion rights, the human rights approach is best. We leave the law to talk its language, but we provide what we can do within our means. And that enables us to have another fallback position, value clarification. If you feel you cannot talk to somebody about contraception, don't. If you don't provide, you can't provide safe abortion, don't. I don't. I mean, don't. But we don't want women to die from abortion complications. But we acknowledge those people who have the courage and their values, we respect them, who provide and talk about advocacy for those products which can enable them to achieve abortion safely. That is my position. That is the official position I hold in our position paper. Thank you very much.
Just to clarify one point, this is not somebody's agenda. Okay? This is our agenda. We are professionals, we are not politicians. It is because, like, as I said, 7 million annual deaths because of unsafe abortion. As an OB/GYN professional, if it doesn't concern us, why did we become an OB/GYN professional in the first place? We are here to use maternal death, regardless of the cause. It's not selective addressing of the cause of maternal death. We have to address it in total. So this is our agenda, and nothing more than is our agenda. Okay? So there is no agenda behind this. It's a free discussion. And as I said, as a professional, we are not lawmakers. Lawmakers are politicians. But within the scope of the law, we should advocate for the useful use of the law. Okay? If a woman is raped, for example, is this a problem in Africa? No, it's not a problem. It is a community needs to protect her, the government needs to protect her, and yet she comes to us. We shouldn't be politicians by our very so okay? So we need to have some remorse for the huge number of days, okay? Especially in Africa, as long as we are here in the profession for life. Okay? So that has to be very crystal clear, and there is no agenda at all behind this discussion. It's an open discussion, okay? So maybe
I think, for example, our approach in Ethiopia, I don't think it's necessarily from top to down. Rather, I would see it from bottom to up, because women associations, lawyers associations, we providers of healthcare providers for women who are seeing the problem and are pushing the agenda, and there was stiff resistance from above, from the government, parliamentarians, because of their values and so on. So when we are pushing, it's on the behalf of the women, and I see it, we are starting from below to push to change the laws and so on from above. And starting from the community, because of its sensitivity, I think should be, there are some challenges of the nature of the topic itself. Who is the community? Sometimes there's a possibility that the agenda, women's rights might be hijacked by others, like supposedly representatives of the community, let's say the religious leaders and so on. So are we we're going to call them part of the community? They are going to hijack and push the women rights agenda because of their values and attitudes. Many women, okay, who are supposed to be represented by them or by the other community members, there is a possibility of their rights and so on being hijacked. So I just want to mention that it might not be straightforward like other living in conservative societies which all of us live in. Thank you.
Summarizing, I'm not sure, but yeah, thank you. I was really reflecting on the approach, bottom up, top down. To be honest, the issue of abortion, I'm not even sure who's at the bottom, who is on top, because it affects all of us in some way, either individually or our mothers, our sisters. So there's even I don't see, maybe it is a horizontal approach. So it's not even like we are trying to discuss things which are very far from us. It's just within us. And when we discuss these things, it's interesting who is in the audience. Everyone, even the policymakers are there, and they are listening. So I think it's good, it's healthy. Even in this very room, I see people who are in very serious positions of responsibility and policy making, listening and quietly, like Professor Andrea Pembe there, the VC of MOHAS, of Malede. So everybody is affected. I mean, he's a gynecologist, that's why he's here, but he's a trainer. Professor Pembe is there quietly listening, I know. So, we need to just agree each one to do what they have to do. Those who are comfortable with that, advocating for one of the major driver issues, whether to prevent, to handle the pregnancy, unwanted pregnancies when they happen, the complications, because to be honest, even doing handling of the complications, we are not, and I don't want to repeat this. We've seen cases where women are being referred and delaying care because they are being judged to have induced this abortion. I don't want to go into that. But it remains a difficult issue to discuss, but we just have to discuss and probably we'll make it work. But doing it at the regional level, I think, makes it even more impactful than if we start only as a AOGU here and discuss, then another time Kenya discusses, and another Rwanda. So we are all taking notes and seeing what we can do. Lastly, I think I want to acknowledge that one of our members of the Committee of Practice, Honorable Malede, being now Minister of Health of Ethiopia, she became, I think she's no longer having time. So we also have ministers who know these things very well and their colleagues. So how do we harness that position and then get other ministers or even other policy makers to buy in? Thank you.
So I think for the interest of time, let's time to the session. So I'm very happy for all the panelists, for the warm, for the discussion and the warm participation from the audience. So to wind up, like the role of advocacy, research, and training is very crucial in terms of advancing and advocating abortion rights in Africa, because whether we like it or not, it continues to unfold to be the major cause of maternal mortality. Okay, so every one of us going back home, we need to be a voice for women. So that's the whole aim of this discussion. Thank you very much. That's all. Okay, thank you for all the panelists.